are at risk 5 times in women and twice in men, 40% with acute heart failure. And this is the various pathophysiological mechanism which is beyond the concept, and I'm going to just touch upon how the drug works, how this pathophysiology is going to get altered when we touch upon therapies like ARNI. Diabetes, of course, this has been talked about in all the previous talks as to how diabetes capital we have been mislabeled or dislabeled or disabled by this pandemic that is ensuing in diabetes and ensuing heart failure. So basically, not only it's the inflammation that we talk about causing ischemic cardiomyopathy that we know in diabetics, but more importantly, it's the RAS and the calcium abnormal handling, apart from autonomic dysregulation, which is apart from hypertrophy, all lead to cardiac myocyte disarray and leads to worsening of heart failure. In heart failure in adult diabetic patients, the risk factors would include longer duration insulin usage, poor glycemic control, higher BMI, presence of microalbuminuria, low eGFR, presence of ischemic heart disease, and presence of peripheral vascular disease. If any of these risk factors are present, they all multiplicatively increase the risk of development of heart failure. And there is in type 2 diabetes, 18 milligram % increase in baseline fasting is associated with modest increase in the risk of hospitalization, and 1% in type 1 is associated with 30% increased risk of heart failure hospitalization. So this increase in incremental and multiple risk factors that I've talked about, including dysautonomia and mitochondrial disarray, lipochlorotoxicity, metabolites of the fatty acid metabolism, all of they actually contribute to the same. If we look at the presence of diabetes and heart failure, whether you talk of paradigm HF or you even talk of the CRT therapy, almost 35 to 40% of patients would constitute diabetic population. And it's the lowest was in enalapril study in SOLVE, which was 15%, but that was probably not actually a selection bias rather than the low prevalence per se of diabetes. Even if you look in the other therapy designs, even there, the prevalence of heart failure therapies have ranged in diabetics range from 10 to 30%. And these are strong impact of clinical management of the prognosis in heart failure, whether it's we are talking about especially in the reduced ejection fraction, it's an independent predictor of fatal and non-fatal outcome with worsening of CV mortality as well. In all the trials, when you look diabetic versus non-diabetics, whether you talk of SHIFT trial, ECO trial, ECO-CRT trial, Seniors trial, MERIT-HF, CHARM, beta blocker trials, diabetes is associated with increased all-cause and CV mortality in heart failure, from ranging as from 50% to 5% in various studies. So it's a strong predictor not only for worse outcomes with incremental risk ranging from 1.2 to 1.9 fold, and the impact of diabetes on clinical outcome at 1 year itself has 7% increase in the risk of CV death with 27% increase in risk of heart failure hospitalization. And if you look at the long-term mortality rate, 50% amongst heart failure patients would be with diabetes. So heart failure is frequent forgotten complication of diabetes, and that's why an ARNI has to find its place. And I'll touch upon two other aspects that ARNI alter in managing or improves upon in managing heart diabetes in patients who are put on this therapy. So unmasking heart failure early in patients with diabetes is imperative because 50% individuals with LV dysfunction remain undiagnosed and untreated. And moreover, clinicians should not overlook diabetes patients with stable CAD who may present with atypical symptoms just like dyspnea or discomfort, no angina actually. And early diagnosis can help to prevent worsening, including heart failure hospitalization or debilitation. Now we know that before all the trials I touch upon the ARNI, I want to go and take you on to background of the therapies that we exist before the paradigm actually happened, which included the ACE and ARNI, of course, now coming as the centerpiece of the therapy. Beta blockers, diuretics have been in the place, but the inotropic therapy, enoxaparin, milrinone, etc., have disappointed. Even nesretide, which was a recombinant BNP, actually failed. And there are some more recent, which I'll, if time permits, will touch upon to some extent. Now, we know that management of heart failure in diabetics should be focusing around not only the diabetes control, but also look at the heart failure remodeling. And that would, apart from an SGLT2 and the other beta blocker therapy, you would always look at the ARNIs because of their neurohormonal activation, apart from nelpresin activation, which can be blocked by this dual pathway. And apart from the GLP-1 analogs also playing in some role in inhibiting inflammation, the therapy in a heart failure would hence be focused from a diabetologist perspective around SGLT2, GLP-1 analogs, to some extent ARNIs as well, apart from metformin. So we know that trials have shown in diabetics also. I've looked into the various therapies and diabetic population kind of analysis here. So in diabetics, ACE inhibitors, ARB, beta blockers, mRNA, ivabradine, in all their important trials like SOLVE, SAVE, renal on target, emphasis at heart failure shift trial, all actually showed that the impact was irrespective whether patients were diabetic or not. So this is the common donkey analogy that we talk in heart failure. This is either you reduce the number of sacks on the wagon, the heart is a tired donkey taking the increased load on its wagon, and you can unload it by the dilators, the diuretics and ACE, and now of course the ARNI, or you can put a carrot to the donkey and make him flog, which is going to be harmful in the long run, the digitalis compound like therapies. But if you limit and make the donkey accept that the donkey is going to run slow, probably you can be able to take it more longer. But very important, you put skates to the donkey, and then you can actually roll the donkey pretty fast, which is the receding therapy. So neither the R, apart from the recent advances, not only would be several anti-diabetic drugs have been implicated in worsening, like the glitazones, but very importantly, now we know as for SGLT2 therapies, which actually form a cornerstone in managing diabetes if there is heart failure. Of top of that, we have ivabradine, ARNIs, the IV iron therapies in form of confirm HF trial, epigenetics, and you now have new devices like vagal nerve stimulation device. Now let me focus on Vymada, which is the therapy today that we are supposed to be talking. It's the pharmacological biotarget. Basically, naltrexone is actually the pathway which modulates and metabolizes the bradykinin. Now, bradykinin is the one that we always blame for cough, but remember that this also is a potent vasodilator through the bradykinin 2 receptor. And it not only reduces the blood pressure, increases nitric oxide, and increases natriuresis, but may have important effects in the remodeling and further improvement in reduction in the preload. So BNP itself, though being an important parameter, which is responsible for, that's why people actually evaluated necessitide, but it failed. But we know that probably bradykinin and BNP both may have benefits on the preload aspect, apart from the afterload reduction that ARNIs, valsartan would give, that the therapy may have additional benefits which you can get out of this therapy. And hence the neuroendocrine balance, which was to balance between the ANP and others versus catecholamine ROS on the other side, which we are taking care of with valsartan and beta blocker. You would wish that you can balance the sacubitril mediated inhibition to balance out the vasodilators with the vasoconstrictor neutralizing effects of the other therapies. And that's how the equilibrium would finally achieve with the ARNI therapies. And we know very much now from this trial, which actually Paradigm HF showed that there was a 20% reduction in primary composite endpoint, including CV death and all-cause mortality by 16%, apart from heart failure hospitalization. But when you talk of diabetes, this is something additional that we are talking about. We are talking about sacubitril valsartan mediated AT1 receptor blockade, apart increasing insulin sensitivity, increasing GLP-1, increasing bradykinin, increasing natriuretic peptide, increasing cyclic GMP in the skeletal muscle, and also decreasing DPP4 activity and hence facilitating beta cell function. And these are the various postulated mechanisms that have been hypothesized how it would probably be facilitating diabetes per se through its various pathways. Now, if you look at two important subgroup analysis of the paradigm with regards to diabetes per se, the first one is comparing the same with enalapril in terms of glycemic control. And second is the effect from time to first initiation for injectable insulin oral anti-hyperglycemic agent in patients who were diabetic. So when you look at the all-cause outcome, of course, there is 20% reduction in the death, but this is very important that it works pretty much well even in pre-diabetics actually. So diabetes, of course, there is benefit, but also there is difference is present across the spectrum of normoglycemic to diabetes, all being statistically significant. If you look at heart failure hospitalization, again, the same across the group, it reduces the same. If you look at quality of life questionnaire, and that also at 8 months was significantly improved, even in pre-diabetics, undiagnosed diabetics, or even diabetics per se, with 17% improvement in quality of life. So even if we look at the change in the A1C, this is something very interesting, that probably ARNIs actually have some amount of anti-diabetic action. They actually end up reducing A1C over a period of 1, 2, and 3 years in the range of almost zero point 0.5. So as the time goes by, probably worsening of the heart failure as it is prevented, maybe the sympathetic and the adrenotoxicity that worsens the glycemic control may also be one of the postulated mechanism, but there might be some other responsible mechanisms as I had elucidated earlier. Even when you look, they all move to a lower A1C category, with 11% more patients move to a lower A1C and 14% less likely to have moved to higher A1C. You can look at the 29% reduction in the requirement of insulin and the safety. Of course, glycemic, it provides better tolerability than enalapril for renal safety. SGLT2 is something that I need to not talk about here. Cupid trial or some other therapy, which I can easily skip. But device therapies have now also looked at the vagal therapies, which people are talking about, and vagal nerve stimulation device actually probably mediate a lot of action through autonomic regulation, which again is Arni talking about. And this is our own publication published in Journal of American College of Cardiology about Anthem study and the Barostim device that we implanted. So the guideline recommendation, of course, there is no constraint in treating the ARNI, and this is the proposed algorithm with regards to device therapy. But what I intend to propose and suggest and emphasize upon is the need of ARNI being so strong in patients with diabetes, with heart failure, that they would not only control diabetes, heart failure very well and reduce the all-come outcome, including mortality, but very importantly, it has got benefits in terms of need for new insulin started, and also some amount of reduction in the A1C per se by giving this therapy. So this is to summarize hyperglycemia, insulin-resistant hyperinsulinemia, and diabetes as a cascade of deleterious effects that contribute to development of heart failure. Heart failure and concomitant diabetes increase risk of morbidity and mortality, which is overlooked in diabetics. There are no specific constraint for the therapy, but heart failure therapy with protective agents against incident diabetes and worsening glycemic control are welcome. And very importantly, Vymada and its anti-heart failure regimes provide clinical improvement in improved glycemic control in heart failure with reduced ejection fraction and with diabetes. And now we know that it has been approved in even heart failure with preserved ejection fraction recently as the new therapy for patients with reduced preserved ejection fraction also. Thank you. Thank you.